All right, let's get right into it. We're going to visually map out the absolute chaos that happens during a neurological emergency. The goal here is to break down the pathophysiology, the why behind what's happening, so these complex ideas really stick with you for your exams.
So here's our game plan. We're going to build this whole picture from the ground up. First, we'll look at the normal setup inside the skull. Then we'll dive into the crisis of rising pressure and see how it just spirals out of control. After that, we basically become detectives, learning to read the body's alarm signals before we look at the main culprits, head injuries and strokes. And we'll wrap it all up with the critical nursing interventions you need to know to break that vicious cycle. Okay, first up, the command center. Look, before we can even begin to understand what goes wrong, we have to get a rock-solid picture of how things are supposed to work. It all starts right here, with the basic anatomy. Now, if you remember one thing, make it this. The skull is a closed, rigid box. It doesn't stretch, it doesn't expand. And inside that box, you've only got three things: brain tissue, blood, and the cerebral fluid, or CSF, that cushions everything. Since the space is fixed, if one of those things increases, say the brain starts to swell, one of the others has to decrease to make room. If they can't, well, the pressure inside that box just skyrockets. This one idea is the key to pretty much everything else we're going to talk about. So let's see what happens when that delicate balance gets totally thrown off. This brings us to the main event, the intracranial pressure crisis. And this isn't just a single event, oh no, it's a dangerous, self-fueling, vicious cycle. So what exactly is increased intracranial pressure, or ICP? Well, it's pretty much what it sounds like. The pressure inside that closed box of a skull starts to rise. This happens when that balance of brain, blood, and CSF gets messed up by something like a bleed, a tumor, or swelling. This pressure right here is the central enemy we are fighting in almost every single neuroemergency. This right here, this is the vicious cycle in action. Let's walk through it. It all kicks off with some kind of injury, right? A trauma, a hemorrhage. In response, the brain starts to swell up. That's edema. Now, because it's trapped in that closed box, the swelling immediately cranks up the pressure. That's our increased ICP. This pressure then physically squishes the brain, pinching off blood vessels and cutting down blood flow. Less blood flow means less oxygen, we call that hypoxia, and brain cells start to die. And here's the really nasty part. As those cells die, they release stuff that causes even more swelling. And boom, the cycle starts all over again, getting worse and worse each time. Our job is to jump in there and break this cycle. Now this is fascinating. This set of signs, known as Cushing's triad, is basically the body's last-ditch, desperate attempt to save the brain. As the brainstem gets crushed by all that pressure, the body goes into panic mode and jacks up the systolic blood pressure to try and force blood into the brain. This creates a huge gap between the systolic and diastolic numbers, a widened pulse pressure. The heart, reacting to this crazy high blood pressure, then slows way, way down. When you see this triad, you're seeing a brainstem on the very brink of disaster. It is an extremely bad sign. So if all this chaos is happening inside a locked bone box, how in the world do we know it's going on? Well, we have to become experts at reading the body's alarm signals. Let's look at how we figure out what's happening from the outside. This is probably the single most important sentence you need to know in neuronursing. I'm not kidding. Before the vital signs go haywire, before any dramatic posturing, the very first and most sensitive sign that something is wrong is a change in the patient's level of consciousness. And it can be subtle, Maybe they're a little more restless or a bit confused. This is the brain's earliest cry for help. Okay, so how do we track that level of consciousness in a way that's not just a guess? We use this, the Glasgow Coma Scale, or GCS. Don't get bogged down trying to memorize every single number right now. Just focus on the three things we're looking at. How are their eyes responding? What's their verbal response? And what's their motor response? You score each one, add it up, and get a number from 3 to 15. The key takeaways: higher is better, and the magic number is 8. A score of 8 or less, that patient is in a coma. You can think of our pupils as a direct window into the brainstem. Their size tells a very specific story. For example, if you see one pupil get big and fixed, what we call blown, that's a classic sign that cranial nerve 3 is being compressed. On the flip side, if you see two tiny pinpoint pupils, that's pointing to damage deeper in the brainstem, in an area called the pons. Now let's talk about posturing. These are awful, involuntary reflexes to pain that signals severe brain injury.
There's decate, where the arms flex in towards the core of the body, an easy way to remember it. This points to damage in the cerebral cortex. But decerebrate, that's even worse. Here, the arms extend stiffly. This tells you the damage is deeper, down in the brainstem. Seeing decerebrate posturing is a very, very grim sign.
Okay, so we've seen the terrible cascade, and we know how to spot the signs. Now let's connect all of that to the most common causes, starting with traumatic head injuries and the hematomas they can cause. Pay attention here, because this is a must-know for any exam. Epidural versus subdural hematomas. The biggest difference is where the blood is coming from. An epidural is an arterial bleed. Arteries are high pressure, so the bleed is fast and dangerous. It's famous for that lucid interval, where the patient seems okay for a bit and then suddenly crashes. It's a massive surgical emergency. A subdural, on the other hand, is a venous bleed. It's slower, more like a leaky garden hose, and causes a much more gradual decline. This is a super critical assessment finding. If you have a patient with a head injury and you see clearish fluid draining from their nose or ears, you have to test it. If you put a drop on a piece of gauze, you might see this, a central spot of blood with a yellowish ring forming around it, like a halo. This halo sign is definitive proof that CSF is leaking out. It means the patient has a basilar skull fracture, which is basically an open door for bacteria to get straight to the brain. Huge risk for meningitis. All right, let's switch gears to the other major cause of neurological catastrophe, stroke. Here, the initial problem isn't pressure from a bleed. It's an interruption of blood supply. It's a brain attack. So there are three main types. You've got thrombotic and embolic strokes, which are both ischemic, meaning they're caused by a clot blocking a blood vessel. Then you have hemorrhagic stroke, which is from a ruptured vessel bleeding into the brain. Now here's the critical takeaway. You cannot, I repeat, cannot tell them apart just by looking at the patient. A CT scan is absolutely non-negotiable because the treatments are total opposites. Giving a clot-busting drug to someone with a brain bleed would be catastrophic. This slide shows a core concept in neurology. Everything is contralateral, meaning it's wired to the opposite side. See how those nerve pathways cross over? The left side of your brain controls the right side of your body, and the right brain controls the left body. That's why a stroke in the right hemisphere of the brain causes paralysis on the patient's left side. But it's more than just movement. A left-sided stroke often messes with language. We call that aphasia. A right-sided stroke can cause something wild called neglect, where the patient is literally unaware that their entire left side even exists. Okay, let's bring it all home. Knowing the why is fantastic, but what do we actually do about it? This last section is all about the essential actions we take to break that vicious ICP cycle and protect the brain. So let's start with a quick question to get you thinking. Your patient has rising intracranial pressure. What is the number one most important thing you can do with their positioning to help? And here's the answer. You get that head of the bed up to about 30 degrees, and you make sure their head and neck are straight in a neutral position. Why? It's pure physics. We're using gravity to help drain venous blood out of the head through the jugular veins. This directly lowers the pressure inside that closed box, and keeping the neck straight makes sure we're not kinking those important drainage pipes. And beyond just positioning, we have a whole toolbox of things we can do. For example, we manage their ventilator to keep their blood carbon dioxide level, or PaCO2, a little on the low side. Why would we do that? Because CO2 makes blood vessels in the brain dilate. By lowering it, we cause those vessels to constrict a bit, which reduces the amount of blood volume inside the skull and frees up space. We also do everything we can to prevent any spikes in pressure, which means controlling coughing, stopping shivering, and keeping the room quiet and calm. Every single one of these actions is designed to reduce one of those three components, brain, blood, or CSF, inside that rigid skull. So we'll end with this thought. We've seen how every little change in consciousness, in the pupils, in a reflex, is a direct message from the brain telling us what's going on. So the ultimate question that your entire assessment is really trying to answer is this: is there enough space and is there enough blood flow? Because in the end, that's what it all comes down to. Everything we do is about protecting the brain's access to those two vital things, space and oxygen.